This is a picture of the actual port, and so what you can see is your skin is right here, and so you can see once the scar heals that you can't see this port because it is completely concealed under the skin. A special type of needle is used to access a port. It's called a Huber needle. There are different styles of Huber needles, typically just on the degree of angle of the Huber needle, and nurses that have been specially trained to access ports can actually access this implanted infusion port with a Huber needle. Patients do have to come into the physician's office or maybe an outpatient clinic and at least once a month have the port flushed when it's not in use. This just outlines some of the advantages and disadvantages of the implanted infusion ports. And so the best thing is they're good for long-term therapy. As I said, they can stay in for months, years. They have a very low risk of infection because they are not continuously exposed to the outside elements. We talked about the fact that the port's hidden, and so it offers cosmetic advantages. And really, overall, it has less, once it's placed, it has less maintenance needed than the other types of CVADs that we've talked about. It does require regular flushing, and this usually is done on a monthly basis. Okay, complications. The chart on 311 really summarizes these nicely, but one is the catheter does become occluded, and a lot of times this happens because they're not properly cared for. So we just need to make sure that we understand what regular flushing is. It varies for each specific type of catheter that we've talked for. The flushing is not the same, so you need to make sure you understand how to flush the various types of catheters. An embolism is a air bubble that can occur if we would be complacent and inject air into the central access device. We have to be very cautious to make sure that when we connect someone to IV tubing, for instance, it's flushed and that it's not full of air, or that when we flush it, we've removed the air from the syringe. This is could be life-threatening. If this happens, the patient would have an air embolism. And remember, all of these catheters actually rest in the superior vena cava outside the right atrium, so it would be a direct bolus of air into the patient's heart. We need to make sure that we monitor the catheter for infection. And so not only do you want to check the insertion site for redness, swelling, exudate, you want to make sure that the patient doesn't have any systemic signs of infection. You want to make sure that you understand what are the policies in your hospital as far as flushing, changing the dressing, changing the tubing, changing the caps, and making sure that when you do these things, you do them with sterile technique. A pneumothorax would only happen after the insertion of the actual catheter. It's possible that during the procedure, the physician could actually nick the lung and cause it to collapse. This is why it's absolutely mandatory that you get a chest x-ray post-insertion, making sure there's no pneumothorax and that the catheter itself is in place. And the other thing is called catheter migration. And this just means that the catheter has actually changed positions. And so you would notice this if your previously well-functioning catheter has become sluggish or you can't aspirate. And if this is the case, then immediately placement would need to be verified. These are just some of the basic nursing management principles for someone who has a central venous access device. We've talked about many of them, watching the site and the catheter for signs of infection. Typically, there's no pain associated with it, so pain associated with the catheter would be something that you would need to follow up on. You need to make sure that you understand your hospital's policy on when to change the dressing, how to clean it, when to change the injection caps and the tubings, how do you flush, and who can remove the catheter. One thing you need to remember, it does require a physician's order, but only certainly, in some hospitals, only certain nurses that have been trained can remove central lines. Tunnel catheters such as the Hickman and Groshon or an infusion port they actually have to return to surgery to have those catheters removed. Most of the time it involves saline flushes and heparin flushes. Just remember you to only use a 10 ml syringe or larger when flushing a central line, and this is because of the pressure that can be generated with a smaller catheter, like a 3 ml syringe or a 5 ml syringe. You could actually rupture the catheter. Flushing technique is important. Typically what you'll do is you'll flush with a 10 ml syringe of normal saline and then follow it with a certain amount of heparin. And so heparin is what is actually staying in the catheter, hopefully keeping it from occluding. That's it for this Explain Everything. Just remember, you guys, you do have NCLEX style questions that will be due the second day of class. So make sure you do the NCLEX style questions on fluid and electrolytes that are at the end of this PowerPoint.